subserosal, submucous, pedunculated, and the cervical fibroid. I will show you a picture that will solve your confusion. The intramural fibroid is the fibroid that is within the myometrium. The subserosal fibroid, outer border of the myometrium. The submucous fibroid, that is bulging into the endometrium cavity. And the pedunculated fibroid, it's a fibroid that is attached to the uterus by a narrow pedicle. And the cervical fibroid arises from the cervix. Now, this is the picture showing you the typical whorl appearance of the fibroid. You can see in this picture. Now, this is the myometrium. Okay, the fibroid that is present in the myometrium is the intramural fibroid. This is the intramural fibroid, and that is arising from the outer part of the myometrium. In the serosa, that is the subserosal fibroid. Now, this is the subserosal fibroid. This is an other subserosal fibroid, but the location of the fibroid is in the fundal area of the uterus. Okay. Now, this is the submucal fibroid. You can see this fibroid is bulging into the endometrial cavity. This is the endometrial cavity. This fibroid is bulging into the endometrial cavity. This is involving the mucus. This is the submucous fibroid. This is also the submucous fibroid, but this fibroid has a pedicle, right? So this is a pedunculated fibroid. The fibroid which is located in the cervix, it's a cervical fibroid. Okay. Now, how the patient present to you? When the patient comes in OPT, mostly the patients, they are asymptomatic. They don't have any symptoms. And the patient comes with some other problem. And when the scan is done, a fibroid uterus is found. So in that case, what will be the management? That we will discuss later on. Okay. So the patient may be asymptomatic. The patient can present with heavy cycles, heavy menstrual bleeding. The patient can have pressure symptoms like lower abdominal pain, lower abdominal heaviness. And if the fibroid is causing pressure on the bladder or the ureter, the patient may have urinary complaints like frequency, urgency, and sometimes, very rarely, the retention of urine. Okay, and subfertility cases are also reported, but you can see in this picture, this is the corneal end of the uterus, right? If the fibroid is pressing this end and blocking the fallopian tube, the patient can present with subfertility. Okay, so the fibroid, they are usually estrogen dependent, right? They have estrogen receptors on it, and in every the monthly menstrual cycles, more estrogen and progesterone are produced, so the size of the fibroid increases. Okay, so there are some risk factors of the fibroid. They are common in reproductive age group, like the women's of 30, 40, the peak age of developing fibroid. The nulliparous women, the women who have never conceived, they are more prone of developing fibroid. Obese women are, it's also a risk factor because the adipose tissue, they produce estrogen. So this may cause the fibroid formation. If the patient has a family history of fibroid, so this can also be a risk factor. And African racial origins, they are 3 times are of higher risk of developing fibroid. Okay, now there may be some complication of fibroid. It doesn't mean that this complication can happen in every patient, but it can. The red degeneration, hyaline degeneration, and sarcomatous degeneration. Okay, now what is the red degeneration? The red degeneration is when there is acute disruption of blood supply to the fibroid during active growth. Now, this complication, it usually happens during pregnancy. It can occur if the fibroid develop during pregnancy. So this complication can be encountered in the patient. It is a type of complication when the fibroid is a blood supply is growing fast. Fibroid itself has no blood supply, but it's receiving its blood supply from the peripheral tissue. So if there is a disruption, there's any stoppage of the blood supply, the red degeneration can occur. Okay. The second type of degeneration is hyaline degeneration, when the fibroid is growing rapidly gradually it overgrows its blood supply. So it progresses to central necrosis. So these fibroids are usually very soft in consistency. Usually the fibroids are firm in consistency. The third complication, the sarcomatous degeneration. The sarcomatous degeneration is the malignant transformation of this fibroid. Means the fibroid is showing some malignant features. If the patient presents with you with a rapid fibroid enlargement, the fibroid is going very rapidly in a short duration of time with increased vascularity and central necrosis. So you may suspect that patient of having development of some malignant features, the malignant changes in the fibroid. So this is an alarming situation. It is very rare, less than 1% or 1:200 ka ratio, it's there, but it can be a complication of fibroid. Okay. Now, how you will investigate, right? If a patient comes to you in OPT, you'll first take history of the patient, and as I've already told you, the patient may have lower abdominal pain, abdominal distension, heavy cycles, pressure symptoms. Then you will further confirm it on examination. On an abdominal examination, you will find a enlarged uterus, an enlarged mass on the abdominal examination. And on bimanual examination, there may be a mass which is adherent with the uterus and it is moving with the uterus. So the abdominal pelvic examination will further confirm your diagnosis. Then you will advise some investigation to the patient. Initially, we start with baseline investigation, all baseline investigation, the urine CPC, random blood sugars, urine DRCS, because we have to rule out other pathologies also. Okay. So in CBC, if the patient is having heavy menstrual cycle, patient may develop anemia. So it means that patient is having problem with the fibroid, right? And then we advise a scan to the patient, that is pelvic scan and transvaginal scan. The pelvic scan, abdominal scan जो होता है वो usually if the size of the fibroid is, if the mass is large, right? And if the size of the mass is very small, so we advise the patient transvaginal scan. So that will confirm the diagnosis of fibroid, right? Okay. Now there are three management options, right? The patient can have can be kept on conservative management, on medical management, and the surgical management. Now, who are the candidates for the conservative management? If the patient's on ultrasound, okay. Okay, conservative management for asymptomatic patient. Okay, for asymptomatic patient, like the patient is having no symptoms. So you can, and on scan, a fibroid is found, but the patient is not having heavy menstrual period, the patient is not having any pain, and it is not bothering the patient. So you can observe them for some period of time. You can repeat their clinical examination, or you can advise them scan after 3 months, after 6 months, or after 12 months, accordingly. In those follow-up scan, if the size of the fibroid is increasing, that is bothering to the patient, that is causing problems to the patient, and if some other problem occur, then you can give them some other management options. The second option is the medical management. If the patient complains of low abdominal pain, heaviness, and fibroid size is small enough, no surgical intervention is required, you can advise NSAIDs, mefenic acid, tranexamic acid for heavy menstrual cycles, combined oral contraceptive pills for the heavy periods. And there is another drug which is usually not used in our OPDs, that is anti-progesterone, but you should be knowing it. That is by the name of mifepristone, and that is advised in a dose of 5 to 10 milligrams for 3 to 6 months. This will reduce the menstrual flow, right? And the last medical option is the gonadotropin hormones, gonadotropin releasing hormones. If they are given to the patient, they reduce the menstrual flow, they cause amenorrhea, no menses in the patient, and it also causes shrinkage of fibroid. The size of the fibroid also reduced with GnRH analogs. But these drugs have many side effects, this GnRH analog, and it causes the most common side effect of this drug is osteoporosis if it is given for 6 to 12, more than 6 months. But you can give for 6 months to the patient, it has very good results. It causes amenorrhea also, and it reduce the size of the fibroid. The last option is the surgical option. The definite, the permanent treatment of the fibroid is hysterectomy. But in all the patients, we don't undergo this surgery because hysterectomy, once the uterus is removed, so there's the women have no fertility option then. So we have some other options also. Number one is hysteroscopic dissection surgery. As I've told you, there are submucous fibroid or pedunculated fibroid that is bulging into the endometrial cavity. So the hysteroscope is inserted in the endometrium cavity and the fibroid is resected. So that can be a surgical option in case of submucous pedunculated fibroid. Submucous fibroid or pedunculated fibroid. The second option is myomectomy. Now, myomectomy is a surgical procedure in which the myoma is removed by giving incision on the uterus, right? And but in myomectomy, there's a risk of recurrence of the myoma fibroid. So this is reserved for those patients who want to preserve their uterus, who want the fertility option, who want to have conceive in the future, in their future life. The third option is the uterine artery embolization. Okay, uterine artery embolization is a embolization of the uterine artery. So this is done by radiologist interventionist, right? And in this procedure, when the embolization of the uterine artery done, this blood supply of the fibroid is disrupted. It's cut off, and the fibroid shrinkage occurs, but it has many complications, post-operative complications, like patient can develop fever, patient can develop infections, and patient can have ovarian failure. So it is not good for those patients who have fertility issues, right? And the last and the definitive treatment is the hysterectomy, that is removal of the uterus. If the patient age is if the patient is having no reproductive age group and her family is completed, so we can give this option to the patient to relieve its symptoms. Okay, so I hope uh, all these things are clear to you. I have some questions here. You can answer these questions. Let us start with this first single best answer. Okay. All are the risk factors associated with fibroid except African ratio, multiparity, family history of fibroid, reproductive age group. You can text also. Yes, the answer is multiparity. Okay. The second question is, which of the following is the selective, selective, no, okay. In the case of asymptomatic fibroid, which is the best treatment option? The conservative management, the medical management, or the surgical management? Yes, it's a conservative management. For the asymptomatic fibroid, if the patient is having no complaints, we can observe the patient and we can keep that patient for follow-up, right? The third is, which of the following complication usually classically occur in pregnancy? The red degeneration, hyaline degeneration, or sarcomatous changes? Yes, it's a red degeneration. Okay, so if you have any queries, you can raise your hands or you can text me. They are very common. Fibroid is very a common gynecological problem in females, and we usually encounter these patients in our OPDs. And so we have questions here. And the patient mostly, as I've told you, the patient are asymptomatic, but the patient can have some other problems also. Acha. See, I've told you in surgical treatment the mammectomy. In mammectomy, what we do, we give incision on the uterus, right, and we remove these myoma. So, but when we remove the myoma, there may be a risk of developing it again. There's a risk of recurrence. But in patients who have fertility issues, this is the best option for them. We remove the myoma and we advise them to conceive in future. One of the complication of the fibroid, as I've already discussed with you, the red degeneration. In red degeneration, when the complication of fibroid occur, the patient presents with acute abdomen, with severe lower abdominal pain, right? If the patient is having fibroid and the patient is having severe pain, so you just keep this in mind that the patient can have one of the complication of fibroid. Okay. And it is also very important that in pregnancy there is no role of myomectomy, intrapartum myomectomy. In pregnancy, the patients are usually managed conservatively. There are no surgeries during pregnancy, no surgical intervention during pregnancy, only conservative management. If any complication happens, this also managed conservatively. Okay, so no role of intrapartum myomectomy. Okay, during pregnancy, there is no role of any surgical management. And so in all these complications, the patient can have acute pain, right? Abdominal pain. If there's also one case, I want to discuss one case with you. If the patient if the patient is pregnant and the patient is having cervical fibroid, so we cannot give trial of labor to the patient because cervix cause the obstruction of the fetus, and there's the difficulty in delivering. So we keep that patient for cesarean section. So there's no if there's a cervical fibroid during pregnancy, that patient is not a candidate for normal trial of labor, right? So we keep those patients for elective cesarean section. Obviously, uh, that cause hindrance in is labor. Uh, so if you have any queries, you can text me. So there's one question. If in pregnancy, if a patient has fibroid, how to manage? So I've already told you that in pregnancy, the fibroid are managed conservatively. Okay, so we no role of any surgical intervention, only conservative and observation. Okay, we observe with scans and we manage conservatively. That's it. Okay, if we are giving combined oral, there's a question if we are giving combined oral contraceptive pills for the treatment, why we are also giving antiprogesterone? Don't we have the opposite mechanism of action? Actually, the thing is, when we are giving the hormones by artificial methods, like the in the form of pills, it will produce the environment it will cause an antagonism like effect, right? So this you must आपने एक mechanism पढ़ा होगा अपना pharmacology में, like if the hormones if they are given, the receptors they become resistant, so this will cause the decrease production of the hormone. This is it has an antagonism like effect, right? So this could be the this is the role, this is the mechanism. Okay, the next question. If even if we embolize uterine would they? There's one question. If we embolize uterine artery, would there be any damage to the uterus? No, there's no damage actually to the uterus. Actually, the blood supply of that area is cut off. Or the research says that there is some ovarian failure found in those patients. So obviously, there is some effect of this intervention. Yes, very good question. If a woman, there's one question asked by a student that a woman undergoing mammectomy, if conceived, would not have the chance of uterine rupture because it's a myoma that expand during pregnancy. Very good question. Yes, there are two things. If if you are removing myoma from the uterus, and if the cavity of the uterine cavity is intact, so there maybe the women can take normal trial of labor in the pregnancy, right? Because the uterine cavity is intact, you are only removing myoma from the outside the cavity, right? For example, I'll show you a slide. See, see this slide. See, if you are removing myomas like this subserosal myoma, but the uterine cavity is intact, okay? So this will not cause rupture uterus in the pregnancy because the cavity is intact. So that patient can take a normal trial of labor. But if you are removing the myoma, if the cavity gets open, if the cavity gets open, so that woman is a candidate for cesarean section in his future pregnancy, right? So we cannot give trial to that patient in which the uterine cavity is open. So when you are doing myomectomy, it is very important to mention either the cavity is open or the cavity is not open. That's a very good question asked by a candidate.